Rio de Janeiro. We're going to start with Dr. João Felipe, please.
Hello, good afternoon. I'd like to thank the invitation to actively participate in this World Congress. It's an honor for me. And I've been studying and working as an exercise specialist, physician in Clinimex for 11 years, doing cardiopulmonary exercise tests. And I would like to thank again the organization for the theme that I got, Oxygen, Pulse, and Cardiopulmonary Test. I think it's an underused variable in the cardiopulmonary test. And it's a matter of many studies of prognostic and diagnostic. How do we handle it? First of all, just a quick resume of the cardiopulmonary exercise test. The objective evaluation of the cardiorespiratory fitness. It helps explain exercise intolerance and the differential diagnosis of dyspnea, and can enhance outpatient evaluation and management of coronary artery disease, and estimate prognosis in heart failure patients. And the assessment, exercise training, or pharmacological intervention effects. And this is very new, the evaluation of surgical risk. This is a very famous slide, and this is an American Heart Scientific Statement published in 2013 by many famous authors, Robert Ross, Stephen Blair, that it was an article published right after the cardiac artery disease guidelines, and that didn't have the cardiorespiratory fitness as a risk stratification factor. And they tried to sensibilize the health professionals to have the cardiorespiratory fitness in the clinical practice, and to assess the cardiorespiratory fitness from the cardiopulmonary exercise test, and demonstrating that low cardiorespiratory fitness was associated with high mortality, and especially with age-adjusted death for 10,000 persons. And it was a very high impact, even if they had moderate cardiorespiratory fitness instead of low, especially for men, and especially for women with high cardiorespiratory fitness. And Jarl Canning is a Finnish author and published many articles concerning the O2 pulse as a predictor of mortality. And he did this in 2006, trying to correlate the relative O2 pulse as a predictor of mortality, as well as the cardiorespiratory fitness. And he did this in a prospective study with more than 1,500 men without coronary artery disease, and showing that the low relative O2 pulse was very related to death, to overall mortality of all cause. And it was 2.5 times more times to related to death from the top quartile to the lowest quartile. And he published again 12 years ago in 2018. Claudia was one of the authors of this paper, and the number of men, it was a little bit higher, 2,000 men in the age then, in a follow-up of 26 years in the coopio ischemic heart disease cohort, which is similar to Framingham cohort, but a little bit more with data in risk factors. And he did expired gas variables and electrocardiogram analyzed. And the main objective was to relate the relative peak exercise oxygen pulse, which is the peak exercise oxygen pulse, the absolute value divided by body weight. So he did this with a lot of outcomes and related to sudden cardiac death, cardiovascular death, and all-cause mortality. And these are the graphs. First one, sudden cardiac death, and the graph is under mortality. And when you have a high relative peak exercise oxygen pulse, it's not related to death. You have a low risk to die. Conclusions of this results: 1,000 subjects died, and the relative peak exercise oxygen pulse was approximately linearly associated with each outcome, and the hazard ratios were there. When relative peak exercise oxygen pulse was below 15, it was higher. Yeah. So adding relative peak exercise oxygen pulse to cardiovascular disease mortality risk prediction model significantly improved the risk discrimination. So VO2 is the rate of oxygen consumption by the tissues measured in expired gases during incremental exercise in increasing intensity. This is the cardiopulmonary exercise test shows us. So the oxygen pulse as a concept is a physiological term for oxygen uptake per heartbeat, which stands for this formula. And it's an interesting variable because it puts together a gas analysis in a chronotropism variable in the cardiopulmonary exercise test. So the oxygen pulse in cardiopulmonary test shows cardiovascular efficiency during exercise and reflects stroke volume during exercise, or systolic volume, as we know in the Portuguese language. It's a very good relation cost-benefit in estimating stroke volume. It helps explain clinical impairment of the stroke volume, and it has a very good impact in the clinical decision-making. So let's go back to the think principle, modified, where VO2 equals cardiac output times the arteriovenous oxygen difference. Let's go to the cardiac output. If we put together the cardiac output formula, we have the heart rate times stroke volume. And if we change mathematically the equation, we have then the VO2 divided by heart rate equals stroke volume times the arteriovenous difference, oxygen difference. So now the left side of the equation we have the oxygen pulse, liters per beat, equals stroke volume times the arteriovenous oxygen content difference. So when we know the three of the four variables, we can estimate the stroke volume. Let's go back to the equation again. So we have the oxygen pulse equals stroke volume times the arteriovenous oxygen content difference, which tend to be a constant. As we know, if the subject doesn't have lung disease, diffusional disorders, if it's until 1,600 meters of altitude, and there's no myopathies or any other diseases that change the arteriovenous oxygen content difference, we have about 13 to 14 milliliters per deciliters of oxygen in this difference. And this represents how much of the oxygen was actually used by the tissue. So considering the arteriovenous oxygen content difference is relatively constant among the individuals, oxygen pulse can reflect the stroke volume, as shown by the formula. So, reflects the stroke volume, which means the heart inotropism and lusitropism, two characteristics of the heartbeat. Crisafulli, in 2007, tried to demonstrate the stroke volume in 15 amateur cyclists with maximum cardiopulmonary exercise test and a cycling ergometer. As you see, the heart rate curve was increasing linearly, the VO2 increases linearly, and the linearly increasing of workload, and the oxygen pulse, the lowest graphic, you see a hyperbolic curve. In a healthy population, and he demonstrated that oxygen pulse as stroke volume was reasonably applicable. So let's do some practical questions. How to analyze the oxygen pulse? Analyze the curve profile for all exercise intensities. Try to measure the absolute maximum oxygen pulse, the maximum absolute VO2 divided by maximum heart rate. And try to take this absolute maximum oxygen pulse divided by body weight. Then we will have the relative maximum oxygen pulse. And try to predict the maximum oxygen pulse, which comes from the formula H predicted maximum VO2 divided by H predicted maximum heart rate. And then you have the percentage of H predicted oxygen pulse, which is the measurement of the oxygen pulse divided by maximum predicted oxygen pulse. So that's the variables you will have after the cardiopulmonary exercise test. So we know that VO2 increases up to 20 times. The heart rate increases up to 5 times, then we will have the oxygen pulse increases up to 4 times. An oxygen pulse has a hyperbolic behavior in a progressively increasing exercise intensity. So we could have 3 kinds of curves. The green one should be the normal one. A little bit flattened should be a suspected one. And a decreasing one, the red one, should be the abnormal one, and very, very suspected. Let's do some warnings and interpretations. Pay attention to early stage or first minute analysis, especially the rest exercise transition. A damping or a plateau analysis at the end of the exercise. Ask yourself, the VO2 continued to rise? Heart rate went up faster than VO2? This will influence the oxygen pulse curve, especially in the last stage. Has there been an abrupt increase in lung ventilation, a voluntary one or even not voluntary, and in the relation VE-VO2? Is the data set of minutes of exercise complete? The gas analyzer has 6 samples during 1 minute, or even less than that. And if you stop the minute before the minute is complete, then you have a few samples in relation to the other minutes of the whole cardiopulmonary exercise test. So try to pay attention to these last samples of your test. So the hyperbolic curve or oxygen pulse physiologic one should be on the left side. And an abnormal one, you have to ask yourself, it's really abnormal, and why this plateau is happening. So pay attention again to protocols, non-linear workload increments, specific clinical condition affecting the stroke volume, especially mitral valve prolapse, aortic valve disease, left ventricle diastolic dysfunction, and ventricular shunts. So in our lab, I have the opportunity to test these two persons and in cycling and then in treadmill, two triathletes, a woman 32 years old with the same maximum heart rate between the tests, and the curves they're kind of look like. But in the cyclohygrometer, you can see a little bit of plateau in the last minute. But in a man, you don't see that. You see almost the same curve. But especially in treadmill, you have a transition between walking and running, and you see a good increase in the beginning that you don't see much in the cyclohygrometer, which is a much more linear incremental test. So we know that this paper, published by a group, the stability of relative oxygen pulse curve during repeated maximal cardiopulmonary testing in professional soccer players in 2 evaluations in different years. We have these conclusions. Extreme values of maximal heart rate do not influence the relative oxygen pulse curve, and probably stroke volume in healthy, well-conditioned young athletes. 20% had a plateau in the relative oxygen pulse curve, regardless of the maximal heart rate values. Physiological limitation, maybe athletes has. Relative oxygen pulse curve, as well as its maximum value, remains stable after interval of 1 year between cardiopulmonary exercise tests. Well, positive points about oxygen pulse. It reflects quite well the behavior of stroke volume during exercise, and has a stability, as we saw later, on repeated cardiopulmonary tests. The profile of the curve is not influenced by the maximal heart rate. It may be very useful for assessing effort-induced myocardial ischemia, and more useful when the stress EKG cannot be properly interpreted, for example, as a left branch bronchial block. So let's do the diagnostic cardiac artery disease. I have a physiological progress in the biocellular mechanism. The figure demonstrates the sequence of metabolic derangements that occur when the myocardium becomes oxygen deprived with progressively increasing workload. So you have first the hypoperfusion, micro and microvascular impairment. Then you have metabolic derangements with biocellular changes in the metabolics. And then you have the stroke volume impairment with that diastolic dysfunction and systolic dysfunction, which happens before the ST deviation and before the angina. So this is an interesting paper in Current Opinion by one of the authors was Rosarina. And on the left side you see a healthy male with oxygen pulse. The predicted peak VO2 pulse was a really predicted peak VO2 for him. And on the right side, you see a coronary artery disease, myocardial infarction, and starting to rehab, as you see the difference of the oxygen pulse curves. But the predicted peak VO2 was the main difference in this case. This is another interesting test that they put together: cardiopulmonary exercise test and myocardial perfusion scintigraphy with 86 individuals, and 36% with transient perfusion defects, with the same peak double product, VO2 peak and aerobic threshold, and the flattening oxygen pulse was only demonstrated in extensive myocardial ischemia, and did not identify myocardial ischemia And the main conclusion was the lower percentage predicted peak VO2 in extensive ischemia, as you see in the graphic. The curve below was the extensive ischemia, but the main conclusion was the lower percentage age predicted peak VO2 also. This is another paper produced by Pela, which demonstrated the flattening of the oxygen pulse curve with this sample, and the flattening right after this inflection. The black one would be the normal, and the ischemia had a flattening right after some point of increasing work rate. So, if you have oxygen pulse flattening, you should have another clinical abnormalities during exercise test, like this. I will not go through all the ones, but you have to have another clinical abnormalities, not only the oxygen pulse flattening. So, like sudden significant dyspnea or pallor or typical or progressive angina or ataxia, peak VO2 very low, and an anaerobic threshold in high percentage of peak VO2, abnormalities in O2 pulse, not alone, sudden increase in ventilatory equivalents as well, especially peak effort, and ST segment changes in complex ventricular arrhythmias, for example. This is the last part, heart failure prognostic. This is a classic paper. Peak exercise oxygen pulse and prognosis in chronic heart failure, 209 heart failure patients, and a treadmill exercise test, 8 to 12 minutes, a follow-up of 19 months in media, in a class 3 heart failure, patients with use of beta blockers. So they have this outcome, and the cutoff was 14 milliliters per beat, and the relative peak of oxygen pulse lean divided by body weight, actually by percentage of fat, and the outcome was more death when the oxygen pulse lean was below 14. For absolute value was 10. So just to show the prognostic. So how to improve it? How to improve the oxygen pulse? The same as the VO2. Refer a serious patient, especially a serious patient, to a supervised exercise program and to CPETs, and ideally daily exercise at optimal levels. Take-home messages. This is the last one. Oxygen pulse reflects the stroke volume in cardiopulmonary exercise tests. The cycling ramp incremental protocol looks better. The relative peak exercise oxygen pulse deals with prognostic. The mean value was 19.5 from the Lau-Cunning article, 2018. The percentage age predicted maximum relative oxygen pulse should be included in your report. The oxygen pulse curve profile at the cardiopulmonary exercise test last part, pay attention to that. And specific clinical conditions could influence stroke volume. Thank you.